Hello everybody. Today we are going to discuss the evidence-based management of the ARDS. We'll start with definition. Definition of the ARDS. There should be the initial insult should be within the 7 days. Then there should be the bilateral pulmonary edema, bilateral pulmonary infiltration, which are not explained by the pulmonary edema, nodules, atelectasis, or pleural effusion. Then the next they have categorized this ARDS into mild, moderate, and severe based on the PaO to PF ratio and based on the so according to the new definition, it is not necessary that patient should be intubated always. Even if the patient is on NIV or CPAP and the PEEP level is up to if 5, and even if the patient is on the high flow nasal cannula requiring flow of more than 30, and if on that, if our PF ratio is between 200 to 300, then the ARDS is mild. If it is 100 to 200, then it is moderate. If it is less than 100, then severe. So similarly, with the help of SPO to FR2 ratio, we can calculate, we can, we can, so by calculating SPO to FR2 ratio also, we can diagnose ARDS. If this ratio is less than or equal to 315, then it is mostly ARDS. What is pathophysiology of the ARDS? So ARDS is the condition initiated and triggered by injury to the epithelial cell and endothelial cell. So ARDS is caused by injury to the epithelial cell, then it is because of the direct cause. If it is caused because of the injury to the endothelial cell, then it is an indirect cause. So alveolar epithelial cell, there are of two types. So some are flat cell, that is type 1, and the other are cuboidal cell, that is type 2. So type 1 are the most abundant and more prone for damage, and type 2 cells are responsible for production of the type 1 cell, production of the surfactant, proliferation and transport of iron, and they are less prone to damage. So there are three phases of ARDS. First is exudative phase, then the proliferative phase, and fibrotic phase. Exudative phase occurs due to injury to alveolar epithelial and the capillary endothelium. Then proliferative phase occurs in between 7 to 14 days after initial insult and lead to the repair of damaged epithelial and endothelial cell, restoration of the barrier function and proliferation of the fibroblast. Then fibrotic phase occurs in some patients as a chronic inflammation sets and leading to fibrosis of the alveoli. So pathophysiological consequences of ARDS include the following. That is refractory hypoxemia and shunt, decreased lung compliance, and pulmonary hypertension. So first we'll talk about refractory hypoxemia and shunt. So why the ARDS patient presented with the refractory hypoxemia? So there is a flooding of alveolar space with the protein exudate and the fluid. So alveolar, not only this, the alveolar collapse will occur because of the increased surface tension in the absence of alveolar surfactant. So there is a non-cardiogenic pulmonary edema due to leaky alveolar capillary membrane. So all this lead to mismatch VQ as blood flow through the capillaries in the alveoli, which are collapsed and which are not taking part into the gas exchange. Then decrease compliance. Alveolar flooding and atelectasis, along with the alveolar capillary membrane inflammation, makes the alveolar space very stiff, resulting in non-compliant lung. In the later stage of ARDS, fibrosis also decreases the compliance of the lung. Then this changes leads to the pulmonary hypertension and RV failure. The development of pulmonary hypertension is common occurrence in the ARDS. Pulmonary hypertension developed due to hypoxic pulmonary vasoconstriction and also due to local production of endothelin 1 and thromboxane 8. So pulmonary hypertension can lead to further hypoxia by right to left shunting across the patent foramen oval and end organ hypoperfusion due to right ventricular failure leading to reduced cardiac. So there are 10 golden rules on management of the ARDS. First rule is tidal volume should be between 4 to 6. P-plat should be less than 27. Driving pressure should be less than 15. Respiratory rate should be less than 30. PEEP should be less than 15. Mechanical power should be less than 17. Patient should be in the prone position for 12 to 18 hours. Then the use of neuromuscular blocking agent in the severe ARDS. Recruitment maneuver can be useful, but they are not routinely recommended. And we can consider ECMO and ECOR as a last. So, in the context of this, ARMA trial was published in 2000. So they studied, so according to this trial, the lower tidal volume in patient with acute lung injury and acute and ARDS was helpful in reducing the lung injury. So there is a specific way of calculating tidal volume. So tidal volume was based on this predicted body weight, and the formula for predicted body weight is different for male and female. For male, it is 50 plus 0.19 into height into centimeter minus 152. And for female, it is 45.5 plus 0.19 height into centimeter minus 150. So the tidal volume was predicted body weight into 6. So after the publication of this ARMA trial, people started following lung protective ventilation, which was tidal volume between 6 to 8 ml per kg. Plateau pressure should be below 30 and peak pace should be between 10 to 60. Then in 2004, alveolar trial was published, which compared the effect of high PEEP versus low PEEP in patient with the ARDS. And according to this trial, the higher peak was not beneficial in managing ARDS. Not only alveolar trial, but the other trial like express trial, load trial, also showed the harmful effect of the high peak on the management of the ARDS. So, what is the first way we'll try to understand what is the concept behind applying higher. So higher PEEP can improve the arterial oxygenation, reduce the tidal lung stress and strain, and promote the homogeneous ventilation by preventing alveolar collapse. So the overall effect of the PEEP is primarily related to the balance between number of alveoli that are recruited to precipitate in ventilation and amount of lung that is over-distended when PEEP is applied. So the beneficial effect of PEEP depends upon the recruitment of the lung. So, but the beneficial effect of the PEEP depends upon the type of the recruiter. Type of the recruiter means what I want to say, whether our patient is high recruiter or low recruiter. So, this applied PEEP with the great recruitability will increase in the end expiratory volume from opening of the lung alveoli. So, if our patient is high recruiter, then only there will be the opening of collapse lung units and end expiratory lung volume will increase. And that increase in the peak will definitely help our patient. But if our patient is low recruiter, then this increase in peak will cause the additional distension of already aerated lung tissue, which would lead to further over distension injury, and then that lead to the dynamic strain. So it is very necessary to assess whether our patient is high recruiter or low recruiter before applying the PEEP. So the next question is how to apply that. First we'll apply set the PEEP according to the ARDS net protocol. That will be our empirical PEEP. So if our according to this table, if our FiO2 requirement is 100, so based on this the applied PEEP will be 20. And further, we'll manipulate this PEEP according to the recruitability and we'll see how to optimize this. So there are many methods for the optimization of the PEEP. So first is the pressure volume curve. So pressure volume curve in patient with ARDS set the PEEP near the lower end of the middle linear portion of the curve where the compliance is high and is so-called inflection point. So we need to find out this lower inflection point and the upper inflection point, and 2 points above that lower inflection point where compliance is high will set the peak. This is the diagrammatic representation of pressure volume curve. As we can see here, there is a point where upper reflection point and the lower inflection point, and 2 centimeter above the lower inflection point, our peak is the point where the compliance of the lung will be high and will set the peak. But this method is full of limitation, like a neuromuscular blockage and heavy sedation is required to avoid the effect of respiratory muscle activity. This inspiratory limb of the pressure volume curve is different from expiratory limb, and tidal breathing probably occurs somewhere between these two curves, depending upon the level of the PEEP. In some patient, lower inflection point we cannot identify. Further, substantial recruitment occurs over the lower portion of the curve, and additional recruitment occur at intermediate or even higher pressure in the volume. So, because of this limitation, static pressure volume curve are not used for clinical practice. Then the next method that we can be used is the stress index. Stress index is the coefficient that describes the rate of change in the slope of pressure time curve during tidal inspiration. If the slope of pressure time relationship increase during inspiration, that means if the stress is index is 1, that means our respiratory system is less compliant, perhaps from the over distension of the lung, which results from the application of the P. Decreasing slope of the pressure time curve during inspiration suggests the system is becoming more compliant. So perhaps from the recruitment of the alveoli that were atelectatic and at end expiration. And if our stress index is 1, indicating the slope changes minimally during the inspiration. So if our stress index, as shown in the first figure, if our stress index is less than 1, that means lungs are over distending, and we can increase the peak further. If our stress index is equal to 1, that means we cannot increase the peak further. And if our stress index is more than 1, then there is then we cannot increase our peak further, but we need to reduce them. Now the next is transpulmonary pressure. So there are certain conditions like kyphoscoliosis, abdominal hypertension, which shift the pressure volume curve of the respiration or chest wall to the right, which will elevate the airway pressure without increasing the lung stress. So clinician may underestimate the PEEP required to achieve the adequate lung recruitment because of the concern about the high airway plateau pressure. So the idea of the transpulmonary pressure. Transpulmonary pressure is the pressure gradient from the airway to the pleural pressure. It is more accurately reflect the stress on the lung parenchyma independent of the chest. So, for example, if end expiratory pleural pressure remains within the tolerable limit, and it may be reasonable to consider exceeding conventional airway this plateau pressure limits, and monitoring end expiratory plateau pressure may also help to identify the peak level required to prevent cyclic alveolar collapse. So what I want to say is there are certain conditions like kyphoscoliosis, chest wall edema, so which will have the impact on the airway pressure. So because of that, we might get high plateau pressure. So in this condition, we need to always see the pleural pressure. And if our end inspiratory pleural pressures are remaining within the normal limit, then we can accept this high plateau pressures. So this transpulmonary pleural pressure is the airway pressure minus esophageal pressure. And ideal goals of esophageal manometry to guide PEEP include end inspiratory pleural pressure less than 15 to 20, end expiratory pleural pressure is 0, and transpulmonary driving pressure is less than 10 to 12. So now how to calculate this pleural pressure? So pleural pressure we are calculating with the help of esophageal manometry. Esophageal manometry is the most feasible means of obtaining such a estimate. To measure the esophageal pressure, an air and the liquid filled catheter is positioned in the lower third of the esophagus. And esophageal pressure is believed to represent average pleural pressure in upright and healthy individuals. However, in supine and mechanically ventilated patient with ARDS, esophageal pressure rises by variable amount because of the dorsal shift of mediastinum content and cephalad movement of the diaphragm. And there is some controversy regarding best method for using esophageal pressure to calculate pleural pressure. So in this context, one trial was published in NEGM in 2008, and according to this trial, the ventilator strategy using esophageal pressure to estimate transpleural pressure will significantly improve the oxygenation and compliance. So, and multicenter clinical trials were needed to determine whether this approach should be widely adopted. So, according to this trial, when they follow this transpulmonary pressure guided mechanical setting of mechanical ventilation, then they found it was very useful. But subsequently, one decade later, in 2018-19, the event 2 trial was published, which found this esophageal guided PEEP compared with the high PEEP. Then they found there was no difference in mortality and any mortality from the or days free from the mechanical ventilation. Then the next concept was driving pressure. So what is driving pressure? Driving pressure is pressure required for the alveolar opening. So driving pressure is calculated as P flat minus P. And the functional lung size is the volume of the aerated lung, which is available for ventilation. And the functional lung size is derived from the baby lung concept. Smaller the baby lung, greater the potential for ventilation-induced lung injury. So the driving pressure will be lowest when the PEEP maintains the alveoli at functional residual capacity at the end of expiration. Tidal volume expands the lung within the functional lung size. So there was a trial which was published in NEGM which found that this if this decrease in driving pressure when we keep our ventilatory setting like so our driving pressures are less than 15, then that was associated with the increased survival. So the newer and the elegant method of determining lung recruitability by the PEEP is the recruitment inflation ratio, where it is more than 5 suggests the lung recruitability at higher PEEP. So what they had done in this method is they first increase the PEEP. For example, they calculate the lung compliance at increased PEEP. For example, let's keep the PEEP at 15 and calculate the lung compliance. Then then they reduce the PEEP by 10. That means now again calculate compliance at the PEEP of 5. And the ratio of this compliance should be more than 0.5. So if it is more than 0.5, that means our patient is high recruiter. So we can apply high. So my take on the lesson from this PEEP is means in setting optimum PEEP is what we are following in our ICU is first calculate empirical PEEP based on the ARDS net protocol and then adjust it according to the driving pressure. That means if our patient's FiO2 is 100, then according to ARDS net protocol, empirical PEEP will be 20. Now calculate the driving pressure. If our driving pressure is more than 15, then we need to reduce the PEEP further. So reduce the PEEP till the driving pressure will become less than 50. So not only lung mechanics, we also need to see hemodynamics. So we also need to see whether in that set PEEP, whether our hemodynamics are normal, if our if our right ventricular is functioning properly, then that if all this if we are maintaining the balance between all these things, then I think we have kept the optimum PEEP to the patient. Now the next concept is mechanical power. During mechanical ventilation, the energy changes from the electrical to potential and kinetic. Potential and kinetic and heat energy. as the pressure is generated to move the volume of air known as tidal volume into the lung. It is this transfer of the energy that may affect the lung parenchyma to make the structural changes at cellular and tissue level that may contribute to the lung injury. So this energy transfer from the ventilator to the lung per individual breath is termed as mechanical energy, and energy transfer per unit is called mechanical power. So this mechanical in respiratory physiology by convention, the unit of mechanical power is joule per minute. So this is the formula for calculating mechanical power. So in short, in one line, if I want to say this mechanical power should be less than 70 joule. So despite doing all everything, if our patient is still remain hypoxic, then the next is then the next strategy that we need to apply is the proning. Now, what is the concept behind proning? So let's say divide lung into anterior and posterior. So the alveoli which are present in the posterior portion are compressed, but due to effect of the gravity, the perfusion is maximum in the posterior position. That's why there is vacuum mismatch. So if we apply the prone position, then there is the pressure effect which are causing because of the heart and the mediastinum will be less in the prone position. And the alveoli which are present in the posterior portion will be open. And also the perfusion, the open now. And also the alveoli which are present in the anterior portion will be open. And also the perfusion will be maximum. So because of this, there is an overall increase in the ventilation perfusion ratio. So we'll see what is the mechanical. So not only this, so there are other effects or other beneficial effect of the proning, like reduction in the intrapulmonary shunt, reduction in the ventilator-induced lung injury, reduction in the barotrauma, improvement in the hemodynamics in the preload-dependent patient if abdominal resistance is low. So in this context, the PROSEVA trial was published in 2013, which showed the prone position will decrease the 28-day and 90-day mortality. Now, the absolute contraindication to prone position are limited to the spinal instability. And the other relative contraindications are proposed, like unstable pelvic and the long bone fracture, rheumatoid arthritis affecting atlanto-occipital joint, open abdominal wound, severe burn, late-term pregnancy, increased intracranial pressure, and severe hemodynamic instability. Now about the role of steroid. So there is a next controversial topic about the use of steroid in the ARDS. So in the context of this, the first trial was published in 2007, that is Meduri trial, which showed the beneficial effect of the steroid in a ARDS patient. So the conclusion of this trial was methylprednisolone induces the downregulation of systemic inflammation, was associated with significant improvement in the pulmonary and extrapulmonary organ dysfunction, and there was reduction of duration of mechanical ventilation and ICU length of stay. Then in 2020, the DEXA trial was published when they compared IV dexamethasone versus conventional treatment. So the dose of dexamethasone that they have used in this was 20 mg daily for 5 days, followed by 10 mg daily up to 10 days or until extubation. And conclusion of this trial was early administration of dexamethasone could reduce the duration of mechanical ventilation and overall mortality in patients with established moderate to severe ARDS. Then the next was role of neuromuscular agent. Neuromuscular blocking agents are appropriate for facilitating mechanical ventilation when sedation is inadequate and most notably in patients with severe ARDS. Also, it helps in preventing ventilator-induced lung injury. So in this context, the two trials was published was Accuracy's trial and Rose trial. Accuracy's trial was published in 2020. So according to this trial, in patients with severe ARDS, early administration of neuromuscular blocking agents improved the adjusted 90-day survival and increased the time of ventilation without increasing muscle weakness. Then Rose trial was published in 2019, which showed no significant effect in mortality when they have used the neuromuscular blocking agent in moderate to severe ARDS. So the next concept was the fluid management. So death in patient with the acute lung injury is due to failure of the non-pulmonary organ. So optimum fluid management plays an important role. In the conservative approach, the fluid intake is restricted and the urinary output is increased in an attempt to decrease lung edema, shorten the duration of mechanical ventilation, and improve survival. So the possible risk of this approach is to decrease cardiac output and worsening of non-pulmonary organ function. So the liberal fluid approach essentially reverses these potential priorities and the risk. So the in this context, the one trial was published in ARDS, and according to this trial, there was no significant difference in primary outcome of 60-day mortality. The conservative strategy of the fluid management improves the lung function, shorten the duration of mechanical ventilation in intensive care without causing non-pulmonary organ failure. And this result support the use of conservative strategy of fluid management in patient with acute lung injury. So my take on the fluid management is, so the fact trial showed this conservative fluid management should be followed in the ARDS to avoid the non-pulmonary causes of death. But when the patient is admitted in our ICU, and if the patient is sick, then during early resuscitation phase, we can go for the liberal management. Early means first 48 hours, we can go for the liberal fluid management. And after optimization of the hemodynamics, we can opt the liberal management of the fluid. Then the next is high frequency oscillatory ventilation. So mechanical ventilation is the life sustaining for patient with ARDS, but it can perpetuate lung injury. So repetitive overstretching or the collapse of the lung unit with each respiratory cycle can generate local and systemic inflammation, which contribute to the multi-organ failure and death. So high frequency oscillatory ventilation, which delivers very small tidal volume at very high rate. So initially, it was thought that this high frequency mechanical ventilation will be useful because it is delivering the tidal volume in very low rate. So in this context, the Oscillate trial was published in 2013. So in patients with moderate to severe ARDS, early application of high frequency oscillatory ventilation as compared to ventilatory strategy of low tidal volume and high P does not reduce and may increase in hospital mortality. So Oscar trial compared the high flow with regular practice. The use of high frequency oscillatory ventilation had no significant effect on 30-day mortality in patient undergoing mechanical ventilation for ARDS. So after publication of this Oscillate trial and Oscar trial, the high frequency oscillatory ventilation was not used in the practice. So next mode of ventilation that we can use is the airway pressure release ventilation. So APRV entails the continuous positive airway pressure at high level with intermittent time cycle release to maintain the alveolar recruitment and the lung volume. So patient can breathe spontaneously independent of phase of respiration through biphasic positive pressure circuit. This allows the movement of posterior muscular part of the diaphragm, increasing distribution of ventilation to the dependent posterior lung region, improving ventilation perfusion matching as compared to the movement of anterior tendinous region of the diaphragm during controlled mechanical ventilation. So APRV was initially described as spontaneous mode of ventilation to treat patient with acute lung injury with aim of maintaining lower airway pressure and to allow unrestricted spontaneous ventilation. There are some reports suggesting APRV may prevent progression of acute lung injury in high-risk trauma patients. So APRV was also shown to be effective in reducing CO2 as well as improving oxygenation without increasing minute ventilation in conjugation with reduction in peak and mean airway pressure. So improvement in gas exchange with APRV is related to the reduction in dead space ventilation. So the use of APRV, however, is not widespread. This mode is not available in all commercially available ventilators. Furthermore, the improvement in survival with this mode of ventilation remains to be evaluated. Now the indication of the ECMO. So after following all methods, our patient is not improving. Then we are thinking about ECMO. So what are the indication of the ECMO? At what point we decided to keep the patient on ECMO? So there, according to Evolia trial, there are three criteria. If our PF ratio is less than 50 for 3 hours, if our PF ratio is less than 80 for 6 hours with the optimal ventilatory management and with adjunctive measures, like we have tried everything like paralysis, proning, inhaled pulmonary vasodilator, still our PF ratios are not improved. And if our pH is less than 7.25 and PaCO2 of more than 60, while maintaining P-flat of less than 30 and maximum RR of 35. So if our patient is fulfilling these criteria, then we can go ahead with the ECMO. So in the role of ECMO, there are two trials. One was Caesar trial and the other was Eolia trial. Caesar trial showed the beneficial effect of the ECMO, and the Eolia trial showed the no beneficial effect of ECMO. So if we are keeping the patient on VV ECMO, and then the initial ventilator setting should be driving pressure should be less, PEEP we can keep high PEEP, and RR should be within uh, 10 to 12, 10 to 12 or according to the patient's requirement. And when the patient is on ECMO, consider the serial echocardiography focus to monitor RV function. In patient with the RV failure, consider the reconfiguration to VV ECMO and RVAD ECMO or adding pulmonary vasodilators and the so absolute contraindications for ECMO is catastrophic brain injury and irrecoverable cardiopulmonary disease. Relative contraindications are active hemorrhage, severe coagulopathy, contraindication to anticoagulation, immunosuppression, bone marrow failure, older age, mechanical ventilation for more than 7 days, and expected survival less than 6 months and multi-organ failure. So role of ECOR. ECOR in context of ECOR is mainly used if the patient is in refractory hypercarbia. So in this context, there are two trials are published. One is Supernova trial and the RACE trial. Both trial failed to show the benefit of ECOR. Thank you guys for paying attention.